Hello, peeps. All right, today let's talk about complex atypical hyperplasia and endometrial intraepithelial neoplasia, CAH/EIN. So, both of these simply mean proliferation of endometrial glands. They're disorganized glands with luminal outpouching, cellular mitoses, and nuclear atypia. And there's a picture on the right there. We're going to go over the two main systems of endometrial nomenclature, the WHO 94 and the EIN diagnostic schema. Here's a chart from UpToDate showing actually three classification systems. We're not going to touch on the 2014 WHO. ACOG prefers the 2000 EIN classification system, and so we'll go over that. And then we'll go over the 94 WHO because that's what we used in the past, and there's still, I feel like a lot of people still talk about complex atypical hyperplasia as nomenclature. So it's still good to know where these words come from, what they mean, and are they the same? So here's our focus. So the 94 WHO criteria classifies histology based on glandular complexity and nuclear atypia. The categories are more descriptive in nature, and the pathologists felt interpretation to be more subjective, and therefore needing a different classification system where the 2000 EIN criteria came out. The categories and risk of cancer are listed below. We used to classify this as, or we still do, you still can, penny, nickel, dime, quarter. So penny, nickel, dime, quarter, without atypia and then with atypia. And so because of the descriptive nature of the categories, there was poor reproducibility, and categories weren't exactly suggesting specific management for each category. So again, why they came up with a new classification system. And you can see here kind of where things overlap. So both categories with atypia fall under this EIN category. And as you go to the two categories without atypia, they fall closer to some benign endometrial hyperplasia, which makes sense when you think about it. So the endometrial intraepithelial neoplasia, these were developed to describe three disease categories, as you can see here: benign endometrial hyperplasia, EIN, and then endometrial adenocarcinoma cancer. This has a higher reproducibility. You can see the topography and then the functional categories here, as well as going into some treatment algorithm. And of note, like I mentioned, of the two nomenclature systems, the EIN system is preferable to the 94. And so just diving a little bit into the clinical side, we have retrospective data that shows that when you compare endometrial curettage to the suction curette, EMB, to a DNC, the DNC is less likely to miss cancer than an EMB. So the DNC would pick up cancer in about 50% compared to about 25% of the suction curettage. Then when we look a little bit closer at DNC specimens, the majority of DNC specimens sample less than 1/2 of the uterine cavity. So we're thinking in our minds, maybe we are missing some of the cancer when we're doing just a DNC without like hysteroscopy, no visualization. And so therefore ACOG recommends hysteroscopic directed biopsy when you're very concerned, and therefore this is going to be more sensitive than just a DNC to diagnose a uterine lesion. And most importantly, approximately 40% of patients with EIN will also have a diagnosis of carcinoma on their hysterectomy specimen. And why is this so important? Other than it being a possible test question, this is how we counsel patients on why we would do a sentinel lymph node mapping and dissection for EIN. So you might be thinking, and the patient might be thinking, but I don't have a cancer. Why am I getting a lymph node dissection, or why are you sampling my lymph nodes? But that is because there's a 40% chance that someone diagnosed with EIN will have a cancer diagnosis on final specimen. So knowing this is really important for taking excellent care of patients. That's it. Please ask any questions below. I'd be happy to answer. But otherwise, I hope you enjoyed and I hope you learned something.